Hi, Pramila.
Good evening, Dr. Mala. How are you?
Evening. I'm good.
ये तो आज मोबाइल से ही करना पड़ेगा
So
इंटरनेट
we
का
are now
प्रॉब्लम।
live, ma'am. Sorry for the inconvenience. I'm going live. I'm starting the webinar. So good evening to all respected delegates and faculty members who are present over here. I am Nilesh Darji from Corona Remedies. Welcomes you all in this 186th edition of Happy Learning Masterclass webinar series in association with Ambala, Bhiwani, Bhiwa, Gurgaon, Karnal, and Rohtak. So today's webinar theme is mixed bag, and the convener for today's webinar is Dr. Asha Jain. Let me introduce Madam. Madam has 34 years of vast experience. Currently, Madam is Director SMSA Hospital Raipur, Medical Director CPRS, elected member of Chhattisgarh Medical Counseling, and Madam has Foxy Register Ultrasound Training Center and Colposcopy Training Center. Madam's fields of interest are saving the uterus, fetal medicine, obs and gyne ultrasound, critical care, preventive oncology, and colposcopy. Then Madam is also ISCCP colposcopy trainer. So I welcome Dr. Asha Jain, Madam. And as per the traditional course, we are going to start our webinar with digital lens lightning session. Thank you so much, all respected delegate members and faculties over here. Now I hand over the session to Dr. Asha Jain to take it further. So over to you, madam.
Thank you so much, Nilesh. So, namaskar, all the dignitaries and faculty here on the program. I would like to welcome Dr. MC Patel, sir, whose brainchild is this Happy Learning Master Series. And we have reached 186. He will be giving you the official welcome address. Welcome, sir.
Thank you, Asha. It gives me immense pleasure to welcome you all on 186th edition of this Happy Learning Masterclass web series. And as mentioned prior, joining society Ambala, Bhiwani, Gurgaon, Karnal, and Rohtak. I welcome Dr. Madhu Chaudhary, madam. She has kindly consented to be guest of honor to bless the webinar. I also welcome Dr. Mitra Saxena from Rewari. She has also kindly consented to be guest of honor to bless the webinar. And Dr. Mala Arora from Faridabad. She has also kindly consented to be guest of honor to bless the webinar. All these three guests of honor are always with me in any of my academic activity. So welcome all of you. I also welcome a learned speaker for today's webinar, Dr. Vanna Buria madam from Rohtak. She is going to discuss very interesting topic about septic shock for today's webinar. I also welcome three chairperson to chair that very respective session. Dr. Pramila Malik from Gurgaon, Dr. Rajiv Mahendru from Khanpur Kala, Dr. Anju Markande Ahuja from Rohtak. I also one more speaker, Dr. Ragini Agarwal. She is going to discuss platelet disorders in pregnancy, and to chair that very session, I invite three learned chairperson, Dr. Neeru Thakral from Gurgaon, Dr. Jyoti Malik from Badurgarh, and Dr. Ruby Bhatia from Ambala. And today in reverse panel, panelists will be bombarding question, and being a moderator, I will be answering. And topic will be POXO Act and its relevance in our day-to-day OBGYN practice. So I invite all the learned panelists, Dr. Poonam Lumba Madam from Ambala, Dr. Sugandha Chopra from Ambala, Dr. Om Sila Gulia Madam from Bhiwani, Dr. Ritu Jain Madam from Gurgaon, Dr. Aarti Kaushal from Karnal, Dr. Subhuhi Rizvi from Gurgaon, Dr. Pushpa Dahiya Madam from Rohtak, Dr. Krishna Dahiya Madam from Rohtak, Dr. Bharti Kalra Madam from Karnal, Dr. Renu Chug Madam from Bhiwani, Dr. Nishi Gupta from Ambala, and Dr. Chandan Kachru Madam from Gurgaon. I also welcome Dr. Asha Jain. She is convener for today's webinar, and of course, she is convener in this series since long. I also welcome Dr. Savita Rani Singhal. Just mentioned she is at USA, but for designing this program, she has helped me a lot. So I welcome Savita in her absence also. I also welcome two learned coordinator, Dr. Rekha Rajendra Kumar, President-elect Bengaluru Society. She is in this series since long as a coordinator. And one more coordinator, I welcome Dr. Kiran Chandna Madam, President, Faridabad Society. She is also one of the coordinator for today's webinar. And I welcome all the President and Secretary of Joining Society and all the delegates who have joined this webinar. I usually mention it, and I have mentioned so many times in era of COVID-19, I started this series with 3 friends, and now this continuous 186 episode, now it is 7,000 plus member family as far as Happy Learning Masterclass web series is concerned. Usually we discuss focus topic, and main aim was to meet all our Foxian friends at least on virtual ground and to say hello and to discuss focus topic in our day-to-day practice. So with this little background, I welcome you again, and without wasting much of your time, over to you, Asha Jain. Thank you very much.
Thank you so much, sir. Thank you for that kind welcome address. Now, Dr. Kiran Chandana is here, who's the coordinator along with Rekha Rajendra Kumar ma'am. So, Kiran Chandana ma'am, a few words from you before we start with the official inauguration.
Thank you, madam, for inviting me and making me part of this webinar. I have always liked this program, and I thank Dr. M.C. Patel sir and Dr. Asha Jain ma'am, and I welcome our guest of honor, Dr. Mala Arora, Dr. Madhu Chaudhary, and Dr. Mitra Saxena, and all the speakers and chairpersons and presidents and secretaries of all the Haryana societies. I welcome you all, and it is a happy learning for all of us. I thank Dr. M.C. Patel for this initiative for all of us. Thank you, sir. Thank you.
Thank you. Thank you, Kiran, for kind words, and thank you for all the help you have extended for this webinar. Thank you. Thank you very much.
Thank you. Thank you, Nilesh. May we have the CVs, please? Nilesh? So, I would like to introduce Dr. Madhu Chaudhary ma'am, who did her graduation and post-graduation from PGIMS Rohtak, batch of 69. She's worked at multiple hospitals all over the country, including Srinagar, Bangalore, Kanpur, and Kolkata. Her husband was in the IF till 1987. She is working in her nursing home as head consultant gynecologist since the last 35 years at Karnal, Haryana, and has an experience of more than 30,000 cases. She has been 5 times president of Karnal Association of Gynecologists. She has received many awards from regional clubs like JCI, Innerwheel, BBP, etc. And she has a Lifetime Achievement and Women Achiever Award from Haryana Obstetric and Gynec Societies. So welcome, Madhu Chaudhary ma'am. We would like to hear your words of blessings to this webinar.
Madhu madam.
Madhu ma'am is not in India. I don't know how she has joined in, but she's not in India, is what I heard. So if you permit, we take the program forward.
No issue. And when she can join, we will have blessing from her at
I
that
think she
time.
has joined. She has joined.
But
Yes,
she
she
has
has joined.
joined, but
Yes.
she's unable to speak. Yes, over to you,
Mhm.
Madhu ma'am.
Yes,
I
madam.
think it's a unique program, a program tirelessly done by Dr. MC Patel. Sometime I think, is it older than me? Always it is there, and throughout the country, like me, has been going around. And I just have all my good wishes to everybody. It's so nice to see Dr. Mala, Dr. Mitra, Dr. Jain, and everybody there. And sorry to say, Dr. Savita is not there. All my blessings from the bottom of my heart. This should continue as long as the earth is revolving, maybe. Thank you so much again.
Thank you. Thank you. Thank you, Madhu madam, for
I
kind
think
words.
let's not take more time. We'll hear to the speakers.
Yes.
Requesting Dr. Kiran ma'am to introduce our second guest of honor, Dr. Mitra Saxena ma'am.
I will just say one thing. Don't introduce me to my family.
She's
Kiran.
just family to me, and she's elder sister to me, and very good learner senior from Rohtak Medical College. And she's now chairperson of Practical Obstetrical Committee. She has done so many good webinar, physical CMEs, and internal like RT. She has taught so many people around the country. I really welcome Dr. Mitra ma'am, and she is editor of Foxy Focus Life-Saving Obstetrical Surgery. She has done e-bulletin of building bridges in the corona time also, and she is member of Foxy GCPR Ectopic 2020. She has written chapter on stepwise devascularization of internal iliac artery ligation in PPH book, and chapters on vacuum operative vaginal delivery in PG textbooks of the obstetric. And she's loved by each and every person in Haryana and outside Haryana also. And I see I am a member of unofficial member of Practical Obstetric Committee, and I see so many people love her, and I just adore her and welcome you, madam.
Thank
I
you,
just
Kiran.
want to listen few words.
Thank you very much. At the outset, I'm really honored actually. I was, Dr. Mala, I was asking Dr. Patel, sir, please हमारा status इतना ऊंचा मत करिए. I'm not yet eligible to be a guest of honor. I am just your soldier. Please do
No.
not elevate prematurely. But you know, it's always a pleasure to be associated to focused, good learning. Happy learning means it is enjoyable for everybody who is organizing and all those who are participating and all those who are listening. And sir, I'm really happy. I mean, I'm really grateful to you that the topics that you are making sure that they get across are those कि जिसको जितनी बार सुना जाए, पढ़ा जाए, तो वो स्पीकर के लिए भी बहुत फायदा होता है. आई एम श्योर आवर स्पीकर्स I cannot see Vandana, Dr.
Yes.
Vandana. For you, I mean, of course, you're a teacher in the medical college, but to again consolidate it and put it in those limited time, I'm sure that the exercise of making a presentation so that in that little time we can give the important messages.
Yes.
So I'm really interested that it will be a revision for us, septic shock, and also for Dr. Ragini, that she's taking up this difficult platelet disorders. So, you know, so many times we are in a fix. So I really congratulate our organizers and Dr. Patel sir for making sure that every webinar is of high academic content. And then, of course, the medical legal questions which just keep coming over and over again in the new format. And he is always there to help, not just during webinar, but in real life scenarios also.
Yes.
So I really give all my best wishes to you, sir, and may Ishwar always bless you with
Yes,
good
thank you.
health and success in all your endeavors.
Thank
And
you.
I am grateful that you have given me this opportunity. And of course, I am here to listen to what Dr. Mala will say. and all the speakers and our panelists, everybody. So over to you, Dr. Mala. And of course, I wanted to say that everybody who's in the audience is my sweetheart. I mean, Haryana में है तो ये तो सारे हमारा ही परिवार है. Thank you, sir. आप बार-बार मिलवा देते हो. Thank you so much.
Thank you so much, Mitra ma'am. Thank you so much for those words. और हम हरियाणा में नहीं है पर परिवार तो हम भी हैं आपके.
आप लोग पता है क्या वो मोतियों की जो धागा होता है ना वो
So,
आप सबको जो
requesting Dr. Rekha Rajendra Kumar ma'am to introduce Mala ma'am.
Yeah, thank you, Dr. Asha, for that opportunity. It's my pleasure and I'm happy to introduce none other than Dr. Mala Arora, madam. Madam really needs no introduction, as many of us do know her, but as a formality, let me just put a few words across to all the audience who are here. Madam is FRCOG from UK, FICOG, FICMCH. She was the chairperson of ICOG way back 8 years back, vice president of Foxy more than a decade back, editor of Yearbook in 18, 19, and 20. Madam's passion is on recurrent pregnancy loss, as many of us know and have heard to her lectures on recurrent pregnancy loss. When the word recurrent pregnancy loss at the RPL comes to her mind, it's equivalent to none other than Mala madam. What else to say about her? Madam is a peer reviewer of many reputed journals. Madam, over to you. We love to listen to you, and we are all here eager with our ears open to listen to you.
Thank you, Rekha, for these very kind words. I have to start by saying that Dr. MC Patel is unique. He is consistently been delivering good quality teaching webinars all over the country, not missing out any corner of the country. And I think, Dr. Patel, we must congratulate you for that. I think you are very lucky that you have very good conveners, and I have all my regards for Dr. Asha Jain. She is a very hardworking, dedicated human being. Kiran, my own colleague, and Rekha, who is going to be soon the president of a very prestigious society of Bangalore. Mitra, you are, of course, more than a sister to me all these years that I have known you, and you have worked so hard that your position is elevated to you don't know where. So I am looking forward to hearing from these two speakers. Vandana, you are going to be the first speaker, and we are looking forward to hearing your talk. So are all the delegates, and I would request the delegates to sit back and enjoy this melody of both scientific deliberation as well as medico-legal problem solving. So thank you once again for connecting me to my family. It's been such a great pleasure.
Thank you, Mala, for joining and sparing time to bless the webinar. Of course, you are always with me in any of my academic activity. Thank you.
Thank you, Mala madam, for inspiring words.
Thank you, Mala ma'am. And you know, remembering everyone's names is also a big deal. So your family, fine, but you meet us infrequently and you remember our names. Thanks a lot for that. And now I request Nilesh ji, please share the CVs of the chairpersons of the first talk. And requesting Dr. Rekha, please introduce. Ma'am, you are muted.
Sorry. Yeah, we have finished with our inaugural ceremony and we are into the academic session. In the academic session, the first talk is on septic shock. We request the chairpersons, Dr. Pramila Malik. Madam is a MBBS MD from AIIMS, senior consultant in OBG, past president of Gurgaon Obstetric Society. Madam has keen interest in infertility and high-risk pregnancy. We welcome you to be the chairperson, Madam. Dr. Pramila, Madam, welcome. Dr. Rajiv Mahendru, sir, is another chairperson we are happy to have. Sir is the director of GMC Jin, professor and head of the Department of BPS, Government Medical College, Kanpur. Sir has 58 international publications. That's a real great thing, sir. A great achievement. Invited speaker at umpteen number of international platforms. Chairperson of about 18 sessions in international conferences and prestigious award recipient. Thank you, sir. We love to have you here and hearty welcome to you to the podium. Can I have, yeah. Next chairperson, Dr. Anju Ahuja, madam. She's a consultant obstetrician gynecologist with more than 3 decades of experience. Chairperson of Public Awareness Committee in Haryana OB-GYN Society. Madam is a governor's nominee to the Executive Council, BPS University, Kanpur. She's also the member of the Academic Planning Board, Gurgaon. Hearty welcome again to Dr. Anju Ahuja, madam. I request all the 3 chairpersons to chair this session and take the proceedings. I request the first chairperson to introduce the speaker, second chairperson, sir, to introduce the topic, and Dr. Anju to give the concluding remarks about the talk. Thank you. We welcome you once again, and please take the proceedings. Hello, Pramila madam, Rajiv sir, and Anju madam. Requesting the chairperson's remarks, please. To introduce the speaker, Dr. Vandana Bhuria madam. Hello.
Yeah, good evening, ma'am. And good evening, all my colleagues. So today, Dr. Vandana Bhuria will be talking on septic shock. And it's a very important topic, and we usually come across such cases, and such cases are the ones which may lead to near miss cases also. And Dr. Vandana Bhuria, one of our best colleagues which we have in the area, whom we have in our area, I would request her to start her talk and give us some information on that.
Thank you very much, sir. First of all, I would like to thank all our esteemed teachers today and to give me an opportunity to speak on the topic. I'm just sharing my screen. Is my screen visible?
No.
No, not yet.
Okay.
Vanna, put it on.
Is it visible now, ma'am?
Yes.
Yes.
Yeah, make it full screen. That's all.
Yes.
Otherwise, it's visible.
I'm not able to see my cursor first.
Vanna, make it slideshow.
Yes, ma'am. I'm trying.
Yes.
So, good evening, all of you. Today's topic is septic shock. The objectives for today's talk will be to review the causes of septic shock, describe the pathophysiology of septic shock, outline the treatment options, and explain the importance of a multidisciplinary team approach to improve the outcomes. Shock is the failure of cardiovascular system to maintain effective tissue perfusion. If the effective tissue perfusion is not restored, there is cellular dysfunction followed by organ dysfunction, leading to irreversible shock. Whenever the shock is due to systemic inflammatory response, it leads to septic shock. So septic shock is the most severe complication of sepsis. It is associated with high mortality. Whenever there is sepsis-induced hypotension, that means that whenever the systolic blood pressure is less than 90 millimeter mercury, or there is a drop of 40 millimeter of mercury from the baseline with signs of tissue hyperperfusion despite adequate fluid resuscitation, we label the patient to be in septic shock. Coming on to the etiology. Most commonly, the gram-negative bacterial infection are the most common cause, leading to 62% of the causes of septic shock. And the second most is gram-positive in the 47% of the cases. If we see the organisms, the most common is Staph aureus in 20%, followed by Pseudomonas and E. coli. But nowadays, methicillin-resistant Staph aureus, MRSA, and vancomycin-resistant Enterococci, they are on rising incidence up to 25%. The most common sites of infection are respiratory in 42%, bloodstream in 21%, and genitourinary in 10%. In our patients, most of the time, the patients of septic shock, they are coming of the patients who are having the abortions leading to sepsis, so septic abortion, illegal abortion, second trimester abortions, and also nowadays most of the patients with PROM, if the patients of PROM, they are left for so many days, the patient does not report on time. They are coming with sepsis, and we ourselves have reported one case in which the patient had come after 15 days and there was severe sepsis and we had to do the hysterectomy. So it is very important to diagnose and treat on time. So the risk factors should be are the extremes of age, diabetes, malignancy, chronic kidney and liver disease, use of corticosteroids, any immunosuppressed state, burns, surgery, trauma, indwelling catheters, prolonged hospitalization, or the patients who are on hemodialysis. Discussing the pathophysiology, it is a clinical state that falls along a continuum of pathophysiological states, starting with systemic inflammatory response syndrome and ending to the multi-organ dysfunction syndrome before death. Septic shock results from the spread of initially localized infection into the bloodstream, mostly caused by endotoxin-producing gram-negative bacilli. Endotoxin are the lipopolysaccharide, they initiate cytokine cascade and release the chemical mediators, leading to activation of complement system, kinins, and coagulation system. The TNF-alpha, interleukins, and platelet activating factor and the complement components are activated. Nitric oxide is also an important chemical mediator, which is resulting in sustained vasodilatation, hypotension, reduced reactivity to adrenergic agonist, and further they are characterizing the septic shock. First, I said it is a continuum of systemic inflammatory response syndrome. To any source, there are the first response is inflammation. And if there is any systemic inflammatory response, there are 4 signs. And out of it, these, if 2 are present, then we label it as SIRS, systemic inflammatory response syndrome. So if there's fever, temperature higher than 38 degrees centigrade Celsius, or hypothermia less than 36 degrees Celsius, tachycardia, heart rate more than 90 beats per minute, tachypnea, respiratory rate more than 20 breaths, leukocytosis or leukopenia, with or without bandemia, more than band cells 10%. So if out of these 4, 2 symptoms are present, 2 signs are present, then we label it as systemic inflammatory response syndrome. After the systemic inflammatory response syndrome, there is release of inflammatory mediators, then bacterial endotoxemia is there, marked increase in capillary permeability, and concomitant, there is reduction in peripheral vascular resistance. All these features further leading to hypotension. In hypotension, tissue demands are not adequately met by oxygenation. There is decline in peripheral vascular perfusion and oxygenation. Finally, a shift from aerobic respiration to anaerobic, further ensuing lactic acidosis. And whenever this hypotension that becomes refractory to the fluid resuscitation, septic shock ensues further. Functionally, septic shock is defined by persistent hypotension despite adequate fluid resuscitation. initiation, there is initiation, and despite initiation, and there is need of initiation of appropriate radioactive medications, and further there is progression to multi-organ dysfunction syndrome. So this was the pathophysiology. If we come to the signs and symptoms, whenever there is fever, the signs and signs are of systemic inflammatory response syndrome only. The fever, either there is fever or there can be hypothermia, tachycardia, and tachypnea. Further leading to severe sepsis, there is altered mental status, oliguria or anuria, hypoxia, cyanosis, and ileus. First of all, in early stages, there is a compensated stage of shock in which blood pressure is maintained. There are signs of distributive shock like warm extremities, flash capillary refill less than 1 second, and bounding pulses. This, if the treatment is not provided on time, there is an uncompensated stage, hypotension unfused. Patient may present with cool extremities, delayed capillary refill, and thready pulses, which is a cold shock. And further, if the treatment is not provided, there is continued tissue hyperperfusion, shock is irreversible, and progressive rapidly into multi-organ dysfunction syndrome and death. So how to evaluate? We need to, whenever the patient comes to us in this condition, the respiratory rate is more, fever or hypothermia is there, and then we have to send some investigations and evaluate the patient. So first of all, blood sugars, they can be hyperglycemia, leukocytosis or leukopenia, C-reactive protein is raised, so venous saturation is more than 70%, but PaOT is FiO2 is less than 300. There can be pre-renal azotemia, coagulopathies with INR more than 1.5, thrombocytopenia, hyperbilirubinemia, and lactic acidosis. So we need to investigate the patient. And there is, apart from sending the investigation, we have to do the continuous cardiopulmonary monitoring to allow close observation of the vital sign. The thorough assessment for the end organ dysfunction and peripheral perfusion is done. To objectively define the organ dysfunction, previously SOFA scoring was done, but nowadays Q-SOFA scoring is done so that it is less tedious, less time consuming, and easy for all the specialties. So the score ranges from 0 to 3. And the 3 parts are systolic. If the systolic blood pressure is less than 100, respiratory rate is more than 22, and the altered mental status from the baseline is there. So as the score increases, there is high chances of death or prolonged ICU stay. So presence of 2 or more SOFA points, Q-SOFA points, are risk factors for prolonged ICU stay or death. We have already we need to do the investigations like complete blood count, serum lactates, cultures from all the source like blood culture, urine culture. If intubated, then tracheal culture should be there. If there is any wound of the abdomen or the episiotomy, in our patients like septic abortion, we need to send the high vaginal swabs. And also in cases of prolonged rupture of membranes, high vaginal swab should be sent. And also urine analysis should be done. So coming on to the management, the main goals of the management are to maintain oxygenation and circulation, treat the source of infection, and prevent multi-organ dysfunction. To achieve this, we should follow the multidisciplinary team approach. And management of shock should be the first, and then followed by source control. Ideally, these should be simultaneous. The shock control and the source control, they should be simultaneous, involving the multidisciplinary team. So the management, there are surviving sepsis campaign guidelines, which were released in 2005, and then they were updated in 2016. And according to in 2023 also, they are updated. So the guidelines are, first of all, source control. So broad spectrum antibiotics should be started within 1 hour of the diagnosis. But it should not be forgotten that prior to starting antibiotics, we should send all the investigations like cultures and the blood investigations, complete blood count, liver function test, renal function test, saturation, and the cultures from all the sources which I have mentioned, like blood culture, urine culture, wound culture, high vaginal swabs, and if we had done any evacuation, the product should be sent for the culture and sensitivity. If there is an infected or necrotic tissue, if any there is infected tissue in the abdomen, people come with the cellulitis or any abscesses there, any infected devices, any purulent wound. So we should aim for the removal and we should do the antiseptic dressing. And our aim, suppose a patient comes with a septic abortion, we should do the surgical evacuation, send the products for culture sensitivity. Then how to manage the shock? The measures should be most effective if achieved within first 6 hours of diagnosis. We need to restore the central venous pressure to 8 mm mercury, 8 to 12 mm of mercury. Restore mean arterial pressure more than 65 mm of mercury. Saturation should be more than 70%. Fluid resuscitation should be ideally started with the crystalloids first, and then if blood products is required, if the patient is anemic, then or the patient has thrombocytopenia or patient is in DIC, coagulation profile is deranged, then we should go for the blood and the blood products. And the fluid resuscitation should be aggressive, at least 80 ml. It ranges from 60 to 80 ml per kg per hour. Mechanical ventilation is required if to reduce any metabolic demands. If the patient is in respiratory distress, tachypnea is there, and the patient is not maintaining saturation, only oxygen, then we should start. We should give, and the use of accessory muscle is there. Then the mechanical ventilation should be initiated. And if despite fluids the patient is not responding, we should go for the first line vasoactive agents whenever the shock is fluid refractory. Epinephrine and norepinephrine, they are the agents of choice. Previously, dopamine used to be the first choice, but nowadays it has been said that dopamine has inhibitory effect on the hypothalamo-pituitary axis, and it further confers with the immunological dysfunction. So the first line vasoactive agents are epinephrine and norepinephrine. Antibiotics. Antibiotics should be initiated after sending all the investigation. Within 1 hour, if they are started, they have good prognosis. The most commonly used regimens, they are the 3rd generation cephalosporin with aminoglycosides and metronidazole. And if the patients, if it is a resistant case, then nowadays piperacillin, tazobactam, imipenem, cilastatin, especially in the strains which are nowadays methicillin resistant cases are there. So we are giving piperacillin, tazobactam in the dose of 4.5 gram intravenous 6 to 8 hourly. So if resistant cases are there, we should select the higher antibiotics. What are the goals of resuscitation in first 6 hours? The mean arterial pressure more than 65, systolic blood pressure more than 90, CVP 8 to 12 centimeter of water, and urine output should be more than 50 ml per kg per hour. Central venous saturation should be more than 70%. Lactase Reg has 10. We have to stand the lactase as the patient has come. It should be less than 2 millimoles per liter. And then perfusion pressure should be more than 200. SpO2 should be more than between 80 to 92%. Hemoglobin should be more than 7 gram per deciliter. Sugars should be less than 180. Acid-base disbalance should be corrected, and no dyselectrolytemia is there. In some of the studies, it has been said that if there is no response despite all the treatment we have given, so we can try corticosteroids. They are indicated in vasoactive refractory shock. We have already given the vasoactive agent, but still the shock is refractory, and we can start the corticosteroid. It should be started from the minimal dosage. Addition of vasopressin has been also studied in vasoactive refractory shock. The patient with sepsis have high metabolism and prolonged starvation should be avoided. Early nutrition can help in protecting gut mucosa, prevent the translocation of organisms from GI tract into the systemic circulation. So early enteral nutrition should be started. So coming to the complication of septic shock can be ARDS. It can be chronic, acute or chronic renal injury. Patient can go in DIC. There can be mesenteric ischemia, acute liver failure, myocardial dysfunction, and finally leading to multi-organ failure and death. If we discuss the prognosis, septic shock is associated with mortality rates as high as 40%. Mortality depends on many factors like what is the organism, what is the antibiotic sensitivity, number of organs affected, and the age of the patient. Tachypnea and altered mental status, they are excellent predictors of poor outcomes. Prolonged use of inotropes to maintain blood pressure is also associated with adverse outcomes. So what is the key for successful management? First of all, we should be able to diagnose as soon as the patient comes. We should be able to make the diagnosis earlier. So early diagnosis and start the resuscitation within 1 hour to maintain end organ perfusion. There should be close monitoring and prevention of complication. Drugs that affect the immune system should be discontinued. We should appoint there should be a dietitian. There should who should allow us for early enteral nutrition. The staff nurses, the maker team, they are also an important part of our team. They can help us in DVT prophylaxis and pressure sore prophylaxis. So nursing is also important part of our multidisciplinary team. The clinician should follow culture results and ensure that the patient is on organism sensitive antibiotics. We should maintain the aseptic techniques during procedure. Frequent hand washing should be practiced. So the multidisciplinary team comprising of the clinician, comprising of the ICU team, the ICU nurses, the ICU pharmacist, the microbiologist, and definitely a team of doctors. We should always communicate with each other. If the patient is not responding, we should communicate with the others also. We should not hesitate to take opinion of the nephrologist, pulmonologist to help the patient, so that if we are missing something, we can take others' help for the better care of the patient, for improving the prognosis of the patient. Thank you.
Thank you, Dr. Vandana. It was really a nice talk, and you have talked in depth about the topic, and thank you for refreshing our memory and rather adding more information to what we already know.
Thank you, sir.
Thanks a lot.
Thank you, sir. I think I was very much on time.
Yeah, of course. You have covered the entire topic and well within the stipulated time.
Yes, sir.
I would hand over the mic to Dr. Asha Jain.
Thank you, sir. Thank you. Dr. Promila ma'am, would you like to say something?
Yes. Thank you, Dr. Vandana, for the very nice presentation. I would just like to make few comments, because the septic shock has such a high mortality, 40% mortality once the patient goes into shock. So the maternal mortality, at least 65% of them are preventable if we are very watchful. So we have got MEO score, maternal early warning obstetric signs, which has yellow alerts and red alerts. So if we are filling those charts and we are very watchful, we make the nursing staff very careful about those monitoring. So we can diagnose the patient in the very early stage.
Yes, ma'am, it is
septic shock. And
early diagnosis is the key for successful management, actually.
Yeah. We can start the treatment in the first golden hour in the stage of early sepsis only, so that the mortality goes down to 10% once the patient is treated in the early stage of sepsis without going into septic shock. That's important. So that's what I wanted to comment.
Thank you, ma'am. Nilesh ji, may we have the CVs of the second talk? Ragini ma'am has joined. Requesting Dr. Kiran Chandana ma'am, would you please introduce the chairpersons? Kiran ma'am, you are there?
Yes, ma'am. Yes, ma'am.
Yep. Please introduce the chairpersons.
Now I have privilege of introducing Dr. Neeru Thakral, madam. She is Director, Thakral Hospital and Fertility Gujarat, and she is Diploma Gynae Endoscopy, and she is past Secretary IFS Haryana Chapter, Vice President Haryana Endoscopy Society, and local Organizing Secretary of Fertivision and Principal School of Embryology and ART, Joint Secretary, Cox. I welcome you, madam. And my second chairperson is Dr. Jyoti Malik. She is very active member and of our OB-GYN, and she is medical superintendent JJ Medical Sciences, Institute of Medical Sciences, Bahadurgarh, Director, Roots
Thank you,
IVF.
Kiran ma'am. Thank you, ma'am. We will move forward. We would rather listen to Dr. Ragini's talk.
Okay. And
Thank you.
third chairperson is Dr. Ruby Bhatia, madam. She is.
Thank you, ma'am. Thank you.
Namaskar, ma'am.
Let's,
We
let's
welcome you, ma'am.
listen to Dr. Ragini, ma'am.
Okay, ma'am. Dr. Neeru Thakral or Dr. Jyoti Malik to please introduce Dr. Ragini ma'am for her talk.
Thank you, Dr. Kiran. Yeah, it's my great pleasure to welcome Dr. Ragini ma'am. Dr. Ragini, she is a founder and president, Indian Society of Aesthetic and Regenerative Gynae. She is founder and president of Indian Academy of Cosmetic and Gynec Society. She is the founder, president-elect North India Gynae Forum, founder chapter convener AMW1 Gurgaon, vice president Foxy 2021, general secretary-elect IMS 2425, founder committee chairperson Aesthetic Health India Menopause Society, and she's the founder president Association of Haryana OBG. So it's my great pleasure. Moreover, ma'am, she's a great leader, super academician, excellent human being, and dear, dear friend. So welcome, Dr. Ragini.
Thank you, Dr. Neeru, for your kind introduction. And all my three very favorite person is my chairperson, Jyoti, Ruby, and Neeru. Otherwise, also it is so happy to be there with Haryana.
Yes. Thank you. Thank you.
Mala ji bhi dikh gayi. Hello, Mala. And thank you, MC Patel, sir, for giving me this opportunity. When he was asking me what you want to speak, I thought, let's find out something very different, which we don't get to listen in day-to-day our webinars. So I chosen this topic, platelet disorder, because recently I got a case, and let's start and then I will tell you. So with blessings of Mahakal, I will start my presentation, and the gratitude to each and everyone. Because of that, I am here and have taken lots of material from the net, from their articles. Thank you so much. So my today's topic is platelet disorders in pregnancy, which we rarely discuss in any webinars or in any our CMEs. The patient came to me, a 31-year-old booked Gravida, Gravida 1 para 0 at 36 weeks gestation with a platelet count of 82,000 per liter, and she is in early labor. She does not have a personal history or family history of thrombocytopenia. She has never had symptoms suggestive of an underlying bleeding. The current pregnancy has been uncomplicated. She is normotensive and urine analysis does not demonstrate proteinuria. She does not have any other cytopenias. Liver enzyme and serum creatinine are within normal range. And throughout the pregnancy, CBC is within range of any pregnancy CBC. Now, by the time I reached to the hospital, patient is already 6-7 centimeters. It is very difficult to shift. And I was really thinking, in my hospital, there's no blood bank, there's no ICU, but everything with the God grace has gone well. So I read about the platelet disorder in pregnancy for that patient. And so I am here with all of you. So we all know that the thrombocytopenia is, after anemia, the second most common abnormality of the complete blood count in pregnancy, with reported frequency of 6.6% to 11.2%. and women more commonly diagnosed with platelet disorder during pregnancy because screening is done as a part of the initial clinical evaluation with automated blood counts. Thrombocytopenia can result from a wide range of the conditions, with several of them related to pregnancy. We all know what is platelet. It is a non-nucleated cells derived from the megakaryocyte in the bone and play a critical initiating role in the hemostatic system. Primary hemostasis begins with the platelet adherence to the site of the endothelial disruption, leading to platelet clumping, and which initiate the secondary hemostasis by the coagulation cascade. So this thrombocytopenia should be diagnostically evaluated as early as possible in pregnancy so that the obstetrical management can be accordingly planned to minimize harm to the mother and child. As the various underlying disease share clinical features and the laboratory findings, the differential diagnosis is often difficult interdisciplinary challenge. To define as platelet count less than 1.5 microliter or platelet count below the 2.5th percentile for the pregnant patient, that is 1.16. Because we all know, because of the hemodilution, because of the increased platelet aggregation, the average platelet count in pregnancy is little bit decreased from the, we don't get the value of the 4 lakh, but it is somewhere less than 2. So classification may be mild, moderate, and the severe, depending upon the how much platelet is there. If it is less than 50, then it is severe. 50 to 1 lakh is a moderate thrombocytopenia, and mild is 1 to 1.5. In normal pregnancy, 7.6% of women present with a mild thrombocytopenia during pregnancy. But any pregnant woman, if she has a less than 1 platelet, should undergo the further clinical laboratory assessment. So like any disease, we have to go in detail for the medical history and the physical examination. What is important in the physical examination? See for the petechiae, chymosis, gum bleeding, bleeding associated hematuria and all is very uncommon. But if a patient is suffering from the HUS and all, you may get these findings. So when we talk about the etiological classification, which is more important than your mild, moderate, and the severe platelet counts, because here you are able to get the real picture what the patient is suffering and how you are going to treat this patient. So there might be an increased destruction, decreased production, or there's a sequestration. When we talk about the increased destruction, gestational thrombocytopenia tops the list. Then there may be immunological related thrombocytopenia or non-immunological related thrombocytopenia. Immunological related thrombocytopenia may be because of many reasons. Immune thrombocytopenic purpura is a very common thing which we all know. Otherwise, in SLE, antiphospholipid syndrome, connective tissue disorder also can lead to this platelet dysfunction and the increased destruction. Then drug-induced HIV-related viral infections or the lymphoma can be other causes. Non-immunological related causes, no doubt we see in our preeclampsia, eclampsia patient leading to the HELLP syndrome, then thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, acute fatty liver of pregnancy, heparin-induced thrombocytopenia, vascular malformation, and hypersplenism. Decreased platelet production is found because of the drug-induced aplastic anemia, paroxysmal nocturnal hemoglobinuria, infections, and the bone marrow infiltration. Sequestration may be caused by the following because of the splenic sequestration, portal hypertension, liver diseases, portal hepatic vein thrombosis, myeloproliferative disorders, lymphoproliferative disorder, storage disease, and infection. These causes are found in a very, very less percentage. So the most common cause which we are going to discuss is gestational thrombocytopenia, which is found in the 70% cases, preeclampsia 21% cases, ITP in 3% cases, and other all come in the only 6%. When there is isolated thrombocytopenia, between the gestational thrombocytopenia and immune thrombocytopenia, mostly gestational thrombocytopenia does not occur, gestational does not occur after the outside pregnancy, but immune can occur outside of the pregnancy. And gestational thrombocytopenia never affect the fetus or neonate, but immune thrombocytopenia can affect the neonatal thrombocytopenia, and both can recur in the next pregnancy. Incidence of the gestational thrombocytopenia is 5 to 11%, and it is because of the two main factors. One is accelerated platelet activation, which is suspected to occur at the placental circulation, and accelerated consumption of the platelet is due to the reduced lifespan of the platelets during pregnancy. To diagnosis, maybe there's an asymptomatic patient with no history of the abnormal bleeding, like our patient, and the mild thrombocytopenia is more than 70,000 and usually detected incidentally on routine prenatal screening. No specific diagnostic test to definitely distinguish between the gestational thrombocytopenia or the mild ITP. No antiplatelet antibody test should be done. It has no value. So no pre-pregnancy history of low platelets, no confirmatory test, and platelet count normalized within 1 to 2 months following delivery. So there's no pathological significance for the mother or fetus, and no risk for the fetal hemorrhage or the bleeding complication is observed. Preconceptionally, gestational thrombocytopenia rarely can reoccur in the next pregnancy, and the risk of the recurrence is unknown. During antepartum, monitor platelet count periodically. No treatment is necessary. Invasive approach for the fetal monitoring is not required. Mode of delivery is determined by the obstetric and maternal indication. Epidural anesthesia is safe when platelet count is more than 80,000. Antepartum anesthesia consultation should be obtained to discuss availability of the regional anesthesia. Document return of the maternal platelet count to normal levels of the delivery should be done. When regional anesthesia consideration, one thing is very important is a discussion and the documentation, but most of the anesthetist does not want to give any epidural if the platelet counts are less than 1 lakh. Bleeding time is not useful in assessing the platelet function with ITP or GT. Now coming to our favorite, preeclampsia, which occurs in 3 to 4% and causes almost 21% of the maternal thrombocytopenia. It is usually moderate and platelet count rarely decreases to 20,000. Thrombocytopenia in patients with preeclampsia always correlates with the severity of the disease. A platelet count of less than 1 lakh is diagnostic of the preeclampsia, and it is an indication of a worsening disease and an indication for the delivery. Here, there's an increased platelet consumption, and the vascular endothelial damage increases platelet activation. The initiating factor for the fall in platelets is not known. We all know what are the manifestations of the severe spectrum of the preeclampsia, which is developed towards the HELLP syndrome, which accounts for the 21% of the maternal thrombocytopenia pregnancy. Hemolysis is associated with abnormal results in the peripheral smear. Total bilirubin is more than 1.2, platelet count less than 1 lakh, and the low serum hemoglobin. Liver enzyme, they are elevated in it, and clinical manifestation, we all know that in HELLP is almost maternal mortality rate is very high, and thrombocytopenia is moderate. Major hemorrhage is uncommon, but incisional site oozing or subcutaneous hematoma may occur, and maternal thrombocytopenia reaches a nadir at 24 to 48 hours postpartum. So it is very, very crucial to remember, because these patients of the DIC or HELLP, today we say that these patients should be put on the low molecular weight heparin postpartum to prevent the pulmonary embolism and the DVT in this patient. But remember that 24 to 48 hours are very crucial in this patient, so it should be balanced very properly. Now coming to the fetal and neonatal risk, it may be increased risk for the thrombocytopenia. There are so many studies are there which came to the conclusion, yes, in the HELLP group, certain neonates can develop the severe thrombocytopenia. So HELLP syndrome with thrombocytopenia does not by itself require a cesarean delivery. Although cesarean delivery may be acceptable prior to 32 weeks, maintain platelet counts more than 20,000 for vaginal delivery and 40 to 50,000 for cesarean delivery. Minimum count is controversial. Decisions should be made based on the overall clinical picture. If thrombocytopenia is severe, regional anesthesia block may be contraindicated. Phalansteal incision with primary closure is acceptable for the cesarean delivery. Thrombocytopenia and elevated liver function test commonly worsen the postpartum. Platelets should start normalizing by the third postpartum day. Dexamethasone is not recommended. Coming to the immune thrombocytopenic purpura, it is known as the immune or idiopathic thrombocytopenic purpura. Incidence is 1 per 1,000 to 10,000 pregnancy and accounts for 3% of all thrombocytopenic gravidas. Immunoglobulin G antiplatelet antibody recognize membrane glycoproteins and coat the platelets, which then are destroyed by the reticuloendothelial system, predominantly in the spleen. Antiplatelet antibody may cross the placenta and cause significant fetal thrombocytopenia, which could result in the bleeding complication in the neonate. Minor bleeding complications include purpura, ecchymosis, and the melena, and major bleeding complications include intracranial hemorrhage leading to the neurological impairment or the death in the baby. To diagnose, ITP is a diagnosis of exclusion. The following may be noted: persistent thrombocytopenia, increased number of the megakaryocyte in the bone marrow, exclusion of the systemic disorder or medication, absence of the splenomegaly. Approximately 80% of the cases are associated with antiplatelet antibodies. Now it can be classified by the duration: newly diagnosed, persistent, or chronic. The clinical manifestation, the following may be noted: easy bruising, petechiae, epistaxis, gingival bleeding, and significant hemorrhage is very rare, only when the counts fall to less than 20,000. There are many studies are available for the ITP, and there they came to the conclusion that the babies born with a severe thrombocytopenia, it is very high. Than the 46 women, the 4 infants develop the severe thrombocytopenia. So for the maternal treatment, symptomatic bleeding, platelet counts fall below 30,000 or prior to invasive procedure, initiate the treatment. Treatment will improve maternal platelet counts. None have been shown to adequately prevent or treat fetal or neonatal thrombocytopenia. So remember, you are not going to treat the fetal or neonatal thrombocytopenia. Here you are just treating the mother. So with steroid, the following is noted. Standard initial treatment, according to expert opinion, is response time is 4 to 14 days. Give for 21 days, then taper. Approximately 70% of the patient will respond and 20% will enter complete remission. Risks include hyperglycemia, fluid retention, and the bone calcium loss. If you are giving the intravenous immune globulin, it works by the binding to platelets, blocking the attachment of the antiplatelet antibodies. It is ideal when time is inadequate for the steroid to take effect. Response time is 1 to 3 days. Approximately 70% patient will return to pre-treatment level within 30 days, but treatment is expensive. Now, although there's a very limited data, but there's anti-G immunoglobulin is also used in few cases in non-splenectomized women, and it binds to maternal red blood cells. It is not useful in RS negative or splenectomized women. It is only useful as in the anti-D positive women. With splenectomy, the following is noted. It removes the organ responsible for the destruction of the IgG-coated platelets. Patients should receive immunization for meningococcus, pneumococcus, and Haemophilus influenzae if you are doing a splenectomy in the patient. It does not have an impact on the circulating antibodies that may still cross the placenta and cause neonatal thrombocytopenia. Platelet transfusion is a temporary measure to prevent the threatening hemorrhages. 6 to 10 units of the platelets are usually administered in one time, which raises 10,000 platelets for each unit of the platelets. Other less common causes are, one of the most common cause I can say is a pseudo thrombocytopenia, which you get that then the automated machine this is the platelet value. Then the doctor comes and she said, this, no, this not the 80, it is 1 lakh. So what you have to do? Recheck platelet count in a citrate tube. If the platelet count falls within the reference range in the citrate tube, because normally you take sample in the EDTA tube, pseudothrombocytopenia is diagnosed. If clumping occurs in citrate tube again, it may indicate type 2B von Willebrand disease, in which abnormal von Willebrand factor spontaneously binds to and aggregate the platelets. So recheck platelet count in the citrate tube and go for the Willebrand disease. Remember this thing. Then coming the microangiopathies, which are not very common. They are present as a thrombotic thrombocytopenic purpura or hemolytic uremic syndrome, characterized by the thrombocytopenia, hemolytic anemia, and the multi-organ failure. Incidence is 1 in 25,000 birth, and they are often mistaken for the help, often leading to delay in the diagnosis and the treatment. Etiology is unknown, and it leads to an end organ ischemia. TTP is known for the central nervous system involvement, while HUS predominantly affects the kidneys. If you see, there's a little bit difference in two. TTP has a severe thrombocytopenia, more of the neurological abnormalities, and HUS has acute renal failure, but the symptom many times overlap also, and you find more of the fever in the TTP. So these are the long list for the difference between the TTP, HUS, and the HELP. I'm not going to read. It will take at least 10 minutes. So clinical manifestation, you have to see with often non-specific, lethargy, nausea, vomiting, hypertension may be observed, hemolysis and anemia may be absent in 50% cases. Fibrinogen levels are within the reference range. Fetal and neonatal risk, if you found the perinatal mortality rate is as high as the 30%, because of the preterm delivery, growth restriction, and the intrauterine fetal demises. Plasmapheresis is the first-line therapy. Plasmapheresis removes platelet aggregating substance causing TTP and HUS. It is 90% successful in TTP, but less successful in HUS. Steroids have been used often in conjunction with the plasmapheresis, but steroid alone is less effective. Platelet transfusion should be avoided when possible because they can cause clinical deterioration. Use platelet transfusion only for uncontrolled bleeding on the intracranial hemorrhages. Other therapy are immunosuppressive agent, splenectomy for TTT, hemodialysis for the HUS. Premature termination of the pregnancy has been associated with the relapse. Delivery should be considered only when no response to other therapies occurs. Then other conditions like SLE, APS, hyperesplenism also can cause it. Medication like heparin, zidovudine, sulfonamide also can cause. Then again, viral infection illnesses, we all know that, and platelets are decreased. When we talk about this, disseminated intravascular coagulation is usually associated with bleeding, with the abruption or the postpartum hemorrhage associated with the low fibrinogen. This is very important. Fetal neonatal alloimmune thrombocytopenia, not a maternal thrombocytopenia, but represent the most common cause of the profound fetal neonatal thrombocytopenia and intracranial hemorrhage in the infant. It has no effect on the maternal platelet counts. Incidence is 1 per 1,000 or 2 to 3,000 live births. How it occurs? Maternal sensitization to antigens on the surface of the fetal platelets result in the alloantibodies which can cross the placenta. It involves human platelet antigen. Most common is HPA-1a, and unlike RS disease, alloimmune thrombocytopenia can affect the first pregnancy also. No maternal clinical manifestation. Fetal risks include petechiae, ecchymosis, and the intracranial hemorrhage. Intracranial hemorrhage can occur in utero, resulting in the parenchymal damage, proencephalitis cyst, obstructive hydrocephalus. About 52% can be detected by ultrasound before labor starts. Treatment is maternal IVIG, steroid, weekly fetal platelet transfusion of irradiated PA1 negative platelets with IVIG is the emerging as the first-line therapy. Key to prevention is the recognition of a previously affected infant with the alloimmune thrombocytopenia because recurrence is close to 100%. To conclude, gestational thrombocytopenia is the most common cause of thrombocytopenia during pregnancy, but other underlying causes must be considered as well. Look at the remainder of the CBC and smear to rule out the pancytopenia and the platelet clumping associated with the pseudothrombocytopenia. A thorough history and physical examination is important. If no antecedent history of the thrombocytopenia is present and platelet is more than the 70, think about the GT. If platelet counts fall to less than 50 or pre-existing history is there, think for the ITP. Direct or circulating antiplatelet antibodies has no value in the workup of the thrombocytopenia in pregnancy because they usually are non-specific. Cesarean deliveries for the ITP or GT should be reserved for the obstetrical indication only because vaginal delivery itself has not been demonstrated to be a cause of the intracranial hemorrhage. Invasive procedure to determine fetal platelet counts are no longer considered. With ITP, obtain cord blood or at delivery for platelet count and notify the pediatrician to assess neonatal platelet counts. For GT, document normalization of the maternal platelet counts after delivery. This is very, very important. To take home message is the early interdisciplinary evaluation of thrombocytopenia in pregnancy is a prerequisite for the optimal care of the mother and the child. The development of the evidence-based recommendation for interdisciplinary management should be a goal for a near future. Thank you so much for your patient hearing. And
Thank you, Dr. Ragini, for such a detailed explanation for thrombocytopenia. I think we all have learned a lot, the conditions which we never think of. You have apprised us of those conditions and we'll be wiser in future. I just want to add 3 things because in my life, what I've seen, patient comes normal, you see everything as soon as CBC comes. By and by, we are getting more and more and more patients of thrombocytopenia. There's no symptom, no bruise, nothing. But always remember to rule out the most catastrophic complications, severe preeclampsia and HELLP syndrome. They may be the early signs, and these days preeclampsia is also atypical in majority of cases. When you see BP may be normal and you do a urine creatinine, albumin creatinine ratio, that will be raised. Like you have to find out the features of preeclampsia. So it's very, very important that we rule out the catastrophic conditions because of low platelet count. I have till date, whatever cases I see, every day there is a patient with low platelet 3, 4, 5. But then they come out to be severe preeclampsia or HELLP syndrome. So we should in detail find out. The second thing is we should never be and always rule out dengue serology, even if patient does not give a history of fever. That is a must do. Third thing is when the patient is in early trimesters, she is not term, we need not bother as long as count is above 20-30,000. We don't need to transfuse patient platelets. But yes, if she is even for vaginal delivery or cesarean near term, we must make it 80,000. So it's a very, really good lecture, madam. And always repeat platelet after delivery on the 5th day. It does not improve immediately. It always improves after 4 days. So these things are very important. As long as patient is asymptomatic, we should just rule out the critical conditions, as ma'am has told us so many. And on to Dr. Jyoti and Dr. Pramila for their inputs.
There's one new terminology, HELP is also coming up.
Yeah.
Not the only HELP.
Yes.
Yeah.
And yes, apply that will be severe preeclampsia only, autoimmune diseases.
Dr. Ruby, can I add something? Hello.
Yes. Hello,
Yeah.
Dr. Pushpa.
Hello,
Yes.
Namaskar. कैसे हैं सब लोग?
Yes.
Good evening, everyone. I just want to know that I don't know whether we are getting or everyone is facing the same problem. Nowadays, the thrombocytopenia patient, they are coming to us in a very bad situation. I think in the last 1 week only, we have lost 4 patients. All the patients, they are being transferred, referred from one or the other place, and they are coming in a very critical situation. We need to transfer them with the thrombocytopenia, with the jaundice, and respiratory distress. So I think in the last 1 week, we have lost 4 patients. So I was just wondering whether something else is there, though. Today only I just had a talk with the ICU colleague, and we are also trying to figure out what can be the reason. In our north area itself, like 10 patients are there in ICU from the gynae department who are having the same problem. Either, yeah. So how come, like, either we are not able to identify them at an earlier stage when they are being referred?
Yes.
That is. So
Delayed
today,
referral.
Yeah.
Delayed referral and delayed recognition of preeclampsia is one
Yes,
of the major reasons we get them in critical situation.
Yeah.
Excuse
We
me,
keep on
ma'am.
thinking
We
it's
need
IT.
to actually wind up this session. So if you could all be fast, because it's already
it's okay.
7:30,
So I
only
think it's
half an hour remains for the panel.
Yeah,
Pramila ma'am, you wanted to say something?
Dr. Ragini, excellent presentation. I just wanted to ask you 2 things. How to differentiate between a gestational thrombocytopenia and ITP, because ITP you said you need to give steroids or IVIG to the mother. So how will you differentiate and start the treatment? And secondly, how to recognize fetal neonatal alloimmune thrombocytopenia even in the first pregnancy? Is it possible to diagnose, or it is only retrospective
it is
after we have
only a
lost one child
retrospective.
and then?
It is only retrospective. You can only have a history, only then you can go. As far as the GT and the ITP is concerned, GTP is usually occur in the late second and the third trimester, very rarely in the first trimester, and the patient of the ITP is not diagnosed beforehand, and she was diagnosed first in the pregnancy.
Okay.
That is the most.
So if you get thrombocytopenia in the very first trimester, you should
think
look
in
for
terms of
ITP.
the ITP.
And antiplatelet antibodies won't help in diagnosing and
No,
treating.
they have said what the literature says that it has no role.
Because that will confirm the diagnosis of ITP and we can start the treatment then.
But the
if we have the
literature says
time.
it has no role.
Okay.
Thank you, Asha ji.
Thank you, ma'am.
Thank you so much, ma'am. It's a
Thank
very
you so
interesting
much.
topic and everybody's interested, but in the interest of time, I'm really sorry. I have to interrupt. So, Patel sir, you're there?
Yes. Oh,
Sir,
yes, we
we
can
start
proceed.
the panel, sir?
Oh, yes.
Okay. So, welcome all the faculties to this reverse panel on POXO Act. Dr. MC Patel sir is the expert and I'm the coordinator of this program. I'm going to introduce MC Patel sir. I know he's been with these societies many times, but it's always a pleasure to remind ourselves of all his achievements, especially when a test is coming. So, sir is a consultant obstetrician gynecologist and medico-legal counselor. He was the VP FOXY 2018, organizing secretary of AICOG 2017, chairperson Ethics and Medico-Legal Committee FOXY 2011 to 13. He has held a position in very many societies, done very many conferences, but the most notable achievement is that he has been a medico-legal advisor to any Foxian in need. In all his lectures, he used to say that keep my visiting card under your pillow and be safe. So he is one person who has continued with that mission. He is easily approachable to each and every gynecologist, not just today, but has been for the last 15 years. The other thing is his consistency, that he is very, very consistent. This is 186th episode. Also, number 3, for the last 21 years, he's been going to the underprivileged areas of the Northeast, offering healthcare services 1 week every year. Again, it's been consistently 21 years. So he is consistent, he's approachable, and he's our very own Dr. MC Patel, sir. Welcome, sir. I welcome you to this reverse panel. That's me. I've been introduced. And this is a small clip from sir.
शुभं करोतु कल्याणं आरोग्यं सुखसम्पदम्.
Respected seniors and dear colleagues, serving Foxy for years together on this auspicious day with folded hands and down head, I seek your guidance, blessings and support to endorse my candidature for the post of Foxy President year 2026, election year 2024. Consistently working for Foxy and trying to visit even a smaller societies and to assist our common Foxian friends in any given situation, I have tried to serve Foxy. I assure to serve Foxy in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना.
So would you like to say a few words?
Yes, so this is my humble appeal to endorse my candidature for post of President Foxy election year 2024. So considering my seniority, sincerity, dedication and easily availability in any odd situation for any Foxian friends, I am always there to assist you, serve you. So please consider my candidature for post of President Foxy election year 2024. Election would be from 1st August to 10 August. And before that, all the society will have to nominate my candidature and it will be in month of May. Thank you. Thank you very much. And this is Dr. Asha Jain's appeal. She is going to contest for post of Chairperson Food, Drug and Medico-Surgical Equipment Committee Foxy. And her election would be from 16th of August to 25th of August, and nomination would be in month of May. So you'll have to nominate her for this post and vote in month of August.
Thank you, sir. Thank you so much. Here are our panelists, and we will be introducing our panelists as they come along in the panel. So we have the president and secretaries of very many societies from Haryana. Before we start the panel proper, sir, there is so much of talk on the POCSO Act. Why do you think it is important for gynecologists to know about it? Is it necessary that we should know about this act of POCSO?
Yes. This POCSO Act, which was enacted in 2012, and some amendment came in 2019. But as far as we gynecologist friends are concerned, usually female children rather, and who are victim of sexual abuse or sexual assault or sexual offense, they are brought to us. So we are the first point doctor for examination of such kind of a patient. We have not only to examine, but we have to treat them. We have to form our opinion whether they are victim of sexual offense or so, and we are under obligation to inform police. Because if we fail to inform, then there is a provision for imprisonment for 6 months, and we cannot afford that. And irrespective of her marital status, many a time in few of the region of India, very early marriage is known. But even if patient is married, but if she is less than 18, and if you think that it is a case of sexual offense, then we have to inform police. And that is why we have to know exactly what is POCSO Act and how far we are responsible to deal with this situation in our day-to-day OBGYN practice.
Thank you, sir. Thank you. Now we have Dr. Poonam Lumba, ma'am. She is the director of Lumba Hospital and IVF at Ambala. She is chairperson of Haryana chapter of ISAR, executive member, honorary librarian, and she's a wonderful singer. So before we started the program, we had a few words from her. Over to you, ma'am.
Yeah, good evening, Dr. MC Patel.
Yes, welcome,
First of
madam.
all,
Good evening.
I would like to convey my best wishes to you and Dr. Asha for your endeavor. And I'm sure with your hard work in the past, you definitely deserve the post. And we are for you.
Thank you.
100%. Yeah.
Thank you.
So my question to you is, who is a child? And what is the POCSO Act? And does POCSO Act include boys also in this?
So as far as POCSO Act is concerned, any person less than 18 years is child. And this act is gender equal. So it addresses both male and female. And as far as POCSO Act is concerned, it is prevention of offense of children related to sexual assault or sexual offenses. So for that, this act was enacted.
I would also like to ask you, is there any difference between sexual harassment and sexual assault?
Yes. As far as sexual harassment is concerned, under with sexual intent, in all the area of POCSO Act, word sexual intent is very much important. If there is a sexual intent of a person, then it comes under POCSO. So any person with sexual intent utters any words or makes any sound or makes any gesture to exhibit any part of body or any object, that in a way that child sees that or listen that words, and many a time makes child to do so, to exhibit some part or to show some body parts or so to him or her or to any other person, then it becomes a sexual harassment. Here there is no need to touch even. So this is sexual harassment. One more area, if anybody is behind the child in social media or physically or so, then also it becomes a case of sexual harassment, and repeatedly or constantly follows or watches or contacts a child either directly or through electronic or digital media, then also it becomes a case of sexual harassment.
Does posting of nude pictures or semi-nude pictures of your own children comes under this?
I mentioned in prior, to utter any words or to exhibit or to show any object or any picture or so, it becomes a case of sexual harassment. And as far as sexual assault is concerned, again, word sexual intent will come. So any person with sexual intent touches vagina, penis, anus, breast of child, or make child to do so with him or her or with any other person, then it becomes a case of sexual assault. Here, no penetration is required. Mere touch is enough to prove sexual assault. And in this situation, as far as this sexual assault is concerned, if he makes any child to do so with another child or any other person, then also it becomes a case of sexual assault.
Okay, sir. So what is the punishment as per the law, and any amendments happened in the recent past?
Yes. So there are
Excuse me,
stringent
sir.
punishment.
Sir,
Yes,
may I interrupt for a minute? Dr.
Yes.
Singhal has joined in. So if she would like to say a few words, and then
Yes.
Dr. Poonam can continue.
Oh, yes. Yes, welcome, Savita madam.
Yeah, a very good evening to all. So, and all the best for our own Dr. Patel here with you, sir.
Yeah, thank you, madam.
Wish you all the best for the further elections. And this topic chosen very, very good. I think it is need of the hour to discuss, especially the latest changes which are seen in this act. And all the best.
Yes, thank you, madam.
Thank you.
So I extend my deep sense of gratitude towards you, madam. You are always with me in any of my academic activity, and for this webinar also, you were instrumental for designing this webinar and for execution with Dr. Kiran Chanda madam also. So I am very much thankful, and thanks
Thank you,
for
sir,
joining.
for your kind words.
Even you are abroad and still you have joined. It shows your commitment and love and affection towards this webinar and towards us. Thank you, madam.
Congratulations
Thank you,
to Savita for again becoming a nani.
Yes.
Yeah, thank you. Thank you.
Congratulations.
Yeah, thanks.
Yes. Where were we?
I was asking you, what is the provision of punishment, and was there any amendment recently?
As far as punishment part is concerned, it ranges from 3 years imprisonment and fine to lifetime imprisonment as per different act of this sexual assault or penetrative form of sexual assault or aggravated form of sexual assault, aggravated form of penetrative sexual assault, or using child for pornography. So these are the stringent punishment. And in 2019, there were amendment as far as this punishment part is concerned. And in that very part, under section 376 DC of Indian Penal Code, when more than one person is involved in this act for furtherance of common intention, then even one person has done it, but others are helping, then all the person will be taken into consideration and punishment will be to the all. And if victim is less than 16, in this situation, there is a provision of lifetime imprisonment also. And if victim is less than 12 weeks, then many times lifetime imprisonment, and in few of the cases, death sentence is also awarded in this type of situation. One more amendment came in 2019. Whichever fine is awarded, the amount should be reasonable, and that amount will be given to the patient for treatment purpose and for rehabilitation. So the two good amendment came in 2019 as far as this POCSO Act is concerned.
Thank you,
Yes.
sir.
Yes.
Can we have the next slide, Dr. Asha?
The next is Dr. Sugandha Chopra, ma'am. She's the secretary of Ambala Society, sir, but she is not actually here. So requesting anyone to please take this question.
Poonam madam or anybody from Ambala?
Yeah, I can ask you. So the question is, what is aggravated, aggravated penetrative sexual assault?
So as far as penetrative sexual assault is concerned, I just mentioned, if anybody penetrates penis or any part of body or any object into vagina, anus, nose, mouth, then it becomes a penetrative sexual assault when there is a sexual intent. But when victim is mentally ill or mentally challenged and person is in a position of trust, say for example, family member, a police officer in police station, doctor in hospital, teacher in school. So if persons like this are involved in this activity, then it becomes a aggravated form of sexual assault. And if it is penetrative one, then it becomes a aggravative form of penetrative sexual assault. And for this aggravated form, punishment is still stringent one.
Thank you, sir. And which are the
Yes.
provisions for child pornography?
So if any person involves any child for pornography purpose, then it becomes a case under POCSO Act, and there is a provision of 3 years imprisonment for first instance and 5 years for a second part. But that person is also involved in that pornography, then he will be punished as a sexual assault or penetrative form of sexual assault, whichever the case may be. But merely using child in pornography, there is a punishment for 3 to 5 years.
Thank you, sir. I think we have already covered the amendment as per IPC.
Yes.
You already mentioned.
Yes.
Thank you, sir. Thank you.
Yes.
So, sir, next we have Dr. Omshila Golia. She is the president of Bhivani Society, is a senior consultant with 32 years of practice and life member of ISAR IMA and IMA AMS. Over to you, Omshila ma'am.
गुड इवनिंग मैम.
Good
गुड इवनिंग
evening.
सर. हम पॉस्को
Yes.
के अलावा भी कोई और क्वेश्चन पूछ सकते हैं आपसे?
Ma'am, that can be at the end of the
At the
program.
end, because we will have to cover all the panelists who have joined, and then after we will entertain question if at all.
Okay ji. So now I have to ask this question which is given to me.
Yes.
Yes,
But
sir.
if it is related, any other question related to this case, you
Okay,
may
ji.
ask as a counter question, no issue.
Oh, okay, sir. A 17-year-old girl comes with her boyfriend. She asks for contraceptive advice. What will you do? Can or will you advise?
Yes,
One side-
I will go to this question first. So
Okay,
as
ji.
far as advice of contraceptive part is concerned,
Yes,
so in
sir.
this tricky situation when patient is less than 18,
Okay.
we are facing two situations. One part is our moral duty, because these are the persons, if they have decided to go for sexual active sexual act, then they may end up into unwanted pregnancy, and again they will come to us only for termination of pregnancy. So this is moral part. And second part is legal part. So
Yes, sir.
if we advise them, then it becomes a case of abatement. So under POCSO Act and under Indian Penal Code, there is a definition of abatement. So to instigate any person to constitute crime, or to help any person to constitute crime, or to aid them to constitute any crime becomes an offense. So if we advise them any contraceptive measures, then we may be put into trouble because we are helping them to constitute crime under POCSO Act. So we can advise them sexual education. We can advise not to have any unwanted pregnancy or how to go with safe sex. But if we prescribe any contraception, it becomes a proof, and it could be difficult one for us, because investigating officer may harass you, and in court of law, it will be difficult for us also to face. So better not to advise any contraceptive measures in this group of patients.
So if we want to help her just off level, we can advise her.
It is always there.
Okay, sir.
But on paper, you should not be there in a position that one can prove that you have aided them to constitute crime.
Okay, sir. Thank you, sir.
Yes.
Thank you, sir. Next, we have Dr. Ritu Jain. So she's the president of Gurgaon Society, but she was going to go to the hospital with her mother. If madam is not there, I would request
Anybody from
else
Gurgaon can take.
Gurgaon to take the question, please.
Okay, so I'll take. I'm Dr.
Yes,
Subui,
welcome.
and
Welcome, Subui.
good evening, sir, and thank you for
Good evening.
inviting me in the panel. A 16-year-old girl is brought by her mother with a complaint of vulvovaginitis with discharge per vaginum. On examination, it is found to be a case of STD. She gives history of sexual exposure with her boyfriend. What should I do?
So this is very common situation
very
we are
common.
facing in our day-to-day practice. Vulvovaginitis, discharge vagina, upper vagina. But on examination, if at all we found that case to be of STD, and if she gives history of exposure, or on interrogation, if we come to know that she is a victim of sexual assault, then she is 16 years old girl. So it becomes a case under POCSO Act. Of course, we have to treat that patient, but at the same time, we will have to inform police.
Thank you, sir.
Thank you, sir.
Yes.
This is Dr. Aarti Kaushal, I think. Dr.
Yes.
Aarti Kaushal, who's the president of Karnal Society. Sorry for the mistake, ma'am. She loves dancing and cooking.
Hello, Dr. Asha. Hello, Dr. MC, sir.
Yes, welcome.
Thank you, sir. Thank you so much, and all the best for upcoming elections.
Thank you.
I'll now ask my question. Sir, if a 18 years and 6 months old girl who's married and is brought by her mother, she's 39 weeks pregnant and she's for LSCS. So, sir, in that case, would you go ahead with her LSCS? And also, please mention if this case is if in this case there is any issue of child marriage.
So she is 18 years, 6 months. So
Yes.
she is major at that time. But when she is with 39 weeks of pregnancy, so when she conceived, she was minor. So it becomes a case of POCSO. You have to proceed with LSCS if it is indicated. If you have time to inform police before cesarean section, fine. Otherwise, before this patient leaves your premises, you can inform police. So even if she is major at the time of cesarean section, it becomes a case of POCSO with 39 weeks of pregnancy, and you have to inform police. As far as child marriage part is concerned, because in few of the region in India, early child marriage is known, but it is irregular marriage, not illegal marriage. There is two different things. Irregular marriage means any party to that marriage may withdraw consent and marriage will be voided. But if they are happily enjoying their married life, and when they becomes major, then they are officially considered as a married. So as far as child marriage is concerned, if anybody complains against them about this child marriage, then investigating officer may take action. Otherwise, we have not to comment about our marriage part. We have to simply inform police that she is 18 years, 6 months with 39 weeks of pregnancy. So at the time of conception, she was minor. It becomes a case of POCSO. This is to inform. We are informer. We are not complainant. We have to simply inform.
Sir, do we have to take the patient's consent before informing the police?
No. Patient consent or willingness on part of patient or patient party is not required. Because in this type of situation, usually patient or patient party will refuse to inform police. But even if you have to inform police.
Okay. Thank you, sir. Thank you so much.
Yes.
Thank you, sir. Thank you for making that distinction between a complaint and information. Because we always think if we are informing means it's a complaint, but
No,
that we really need to understand.
So whenever we inform, we have to write like this. This is to inform you that patient so-and-so, aged so-and-so, residing at, had been to me having 6-week pregnancy. That's all. Please do needful is not also to be written. We are informing. What police has to do, that is up to them.
Thank you, sir. Thank you.
Thank you, sir. Now we have Dr. Subui. She's the past secretary of Gurgaon Society. She's a really dear friend. She does a lot of work making people aware. She started a program, Heal India, 2 decades back, and she conducts workshops for adolescents, teachers, and parents in different places. She's also writes poetry and does cooking. So over to you, Subhuhi.
Thank you, Dr. Asha, for the nice introduction. And thank you, sir, for inviting me for this panel. It made me study the whole POSCO Act once again. And actually, we need to revise it very often. My first question would be, sir, in the last case, which I was talking about, Dr. Ritu's 16 years old girl. So does that person goes for the aggravated sexual act, like the punishment will be more than 20 years in such cases? In the previous vulvovaginitis?
Lifetime imprisonment is the provision for punishment as far as aggravated form of penetrative sexual offense is concerned.
For the less than 16 years in this case.
Any less than 18. So when it is a case of POXO and when person is in a position of trust or victim is mentally challenged, then it becomes a aggravated form. Whether it is simple sexual assault or penetrative form of sexual assault. And punishment is much as compared to other offenses.
Okay, sir. Thank you. So now coming to this very common scenario that happens with me in my ultrasound center is that a young girl comes with very early pregnancy with mother. And it's like, of course, if they are less than 18 years, when we explain them that this needs to be informed, the patient and the mother leave. So what should we do in such cases when they leave?
So even if patient takes treatment further with you or not, but once you came to know that she is less than 18 and she is 6 weeks pregnant, so it becomes a case of POXO and you have to inform police. And as far as you mentioned about sonography part, so I would like to mention one real happened case in city of Mumbai only. Patient had a complaint of a pain in abdomen. So mother took her to sonologist directly without consulting any other specialty doctor, physician or surgeon or gynecologist. Straightway she went to sonologist. And on sonography, sonography came to know that she is 16 weeks pregnant. So she told her mother. So mother took baby to gynecologist. The gynecologist examined her. He had been with the report of sonography and gynecologist informed police because she was less than 18. But police went to sonologist. Why you didn't inform police? So in POXO Act under section 19, being a responsible citizen of India, you are under obligation that as soon as you come to know that it is a case of POXO, you have to inform police.
Yes. So, and the thing at times happens that they don't tell us the true age. So I have been like, I have directed my assistants to calculate it from Aadhaar card because that will be the ultimate proof that we have taken.
So,
because
one
they
word
know
of
that less than
caution.
18 is,
Subhuhi, one word of caution. Even if you take Aadhaar card, the Xerox copy, please get it attested by patient and patient party.
Okay.
Because many a time fake Aadhaar card may be produced. So we have to simply go with attestation by patient and patient party so that in court of law, if at all we have to face any such type of situation, then we can say that this card was, I mean, Xerox copy of Aadhaar card was produced by patient and patient party and we had verified by original which was brought by patient.
Okay. So thank you, sir. Because
one of the cases is happened in Tamil Nadu only. It was fake Aadhaar card, patient was minor, and both of our gynecologists were put into trouble.
Sir, thank you so much, sir. So in minor cases only we need the attestation of the party, not in every case. Okay, sir.
But
Thank
even
you.
if in major also, if you can get it attested, it will be always better.
Okay, sir. Thank you.
But
so much, sir,
whenever
because
you are in little doubt that she is in a vulnerable age of 16, 17, 18 or 19 or so, and if you are in a little doubt, always ask for any ID proof which proves her age.
Thank you, sir. Thank you.
Yes.
Thank you,
nice.
sir. Sir,
Yes.
next we have Dr. Pushpa Dahiya, ma'am. She's the president of Rohtak Obstetric Gynec Society, a very senior gynecologist with a teaching experience of 33 years. And she said she actually didn't have time for hobbies. Over to you, ma'am.
Oh, thank you so much, Dr. Asha. Good evening, sir.
Good evening.
Let me first of all say best wishes.
Thank you.
And
Thank
we
you.
hope that you are going to become our next president.
Thank you.
And
Thank
you are the way you are serving the society right now, rather with the more zeal, and you are going to serve the society as well as you are going to help all the Foxians. Best of luck, sir.
Thank
And
you.
now you have given me the opportunity to be there in this panel. So I would like to, very nicely, you are covering the POXO, and you are rather you have revised all the things for us also, because we are getting a lot of patients in Delhi. You can say twice or thrice a week we get such type of patient, one or the other referred from one or the other place. So it's a good revision for all of us. So I would like to know, what's the role of doctor when such victim is brought to us in the hospital, and what is expected under this act about reporting the offense?
So as far as this type of victim, whenever they are brought to us, there are two conditions. Patient has come directly to us with her relative or so, or police has brought to us. If police has brought to us, it's fine. Otherwise, once we come to know that she is victim of sexual offense, then we have to inform police. And before we go for examination, there are certain criteria. First is consent. So patient will give consent for examination. If she is more than 12 years, even if she is minor, then also she can give consent for examination. Because in eye of law, when she is more than 12, she is considered as a mature minor. So she can give consent for examination. As far as any surgical intervention is concerned, say for example, if she is bleeding and if we have to stitch, or there is some foreign body and we have to remove it, then she cannot give consent for that, for surgical intervention. She can give consent for examination only. So in this situation, consent from guardian we will have to take, and we have to proceed further. So first part is consent. Second part is quick history. So what happened, when happened, where happened, how it happened. So in a very simple question, we can interrogate and we can come to know that exactly what has happened. Then comes a examination proper. So thorough examination is very much required. General examination, systemic examination, and local examination in few of the condition. So we have to examine patient thoroughly, and then we have to collect evidences. Say for example, if there is a blood stain or semen stain or any other stain, then we have to collect that also. We have to collect panties, etc., with blood stain or semen or any other stain. So we have to collect for evidences, and then we have to form opinion. So according to us, whether she is victim of sexual assault, and if yes, then we have to inform police. At the time of taking history, two questions, very important questions we have to ask. Exactly when this happened, and after that incidence, did she take bath? Did she change the clothes? And one more thing, at the time of incidence, was she menstruating? Or at the time of examination, is she menstruating? So we have to mention in our history all these questions, because it is also very important that when we come to conclusion or in court of law, when we put our opinion, we have to justify our opinion by history, by examination, and by all the evidences which we have collected. Just one more question.
Yeah. Thank you so much, sir. Very nicely you have reminded us, and the revision for all of us. Yeah. There is another. So in case, what's the provision in case the failure to report or record such type of cases?
Yes.
What
so
can be
under section 19 of POXO Act, we are under obligation to inform police. And if we fail to inform, that under section 21 of POXO, there is a provision of 6 months of imprisonment and fine, or both. And if one is a head of the institution where more than one person is working, then head of the institution is punishable for 1 year and with fine. So if we fail to report. So it is very important to inform police or a CWC, that is Child Welfare Committee member, in this type of situation.
One query, like, sir, to inform the CWC, is there any time limit that within so many hours of examining such patients you need to say?
Usually we should inform as early as possible, because if we do not inform, say for example for 2 days, 3 days, 4 days, and police comes to you that the patient you examine, she was minor, she was case of POXO, why you didn't inform police? So you will tell that we were going to inform, but it doesn't stand in court of law. So immediately, as such, before patient leaves your premises, you should inform. You should inform by letter, by registered post, I mean, by a telephone recording on dial 100. So these are recorded calls. Because once you inform, but you should inform with acknowledgement. Because many times police may turn up hostile that you never inform, you didn't inform. And burden of proof is on your shoulder to prove that you had informed police. So always inform with acknowledgement. If you have sent letter, then send 2 copies and get it signed by person whom this letter you have addressed. And police station officer have buckle number. So name, buckle number, date and time is very much important when you inform such cases.
So another query is there. So you see in CWC, let's say I am working in Rohtak in a PGI. So we have an attached police station, but the patient is coming from far place, and her residence is not coming under our police station. So what to do? Our police station says
once you come to know, you have to inform police station which have jurisdiction of your center, of your hospital. If patient is residing anywhere else or in other jurisdiction, then that police station officer will transfer all those records to that respective police station. That is not your duty to trace that where patient is residing, which is the police station of that very patient as far as jurisdiction is concerned. You have to simply inform police in your jurisdiction.
Why, sir? I
think we need to take it forward, sir.
Yeah. One thing
Ma'am,
is because
you can ask at the end, ma'am. Once these questions are over.
Okay, then, Dr. Asha. Thank you so much, sir.
Dr. Krishna Dahiya, ma'am, is not there. At least I couldn't see her. Krishna, ma'am, are you there?
Then Pushpa madam may continue.
Yeah. So let me find out,
continue.
sir. Yeah. So about the duty of the doctor, how to deal with the case of sexual assault, sir?
Just I mentioned, when this type of patients are brought to us, we have to examine patient, we have to treat them, and we have to offer prophylaxis for STD also, because we never know the accused person could be HIV positive or so. So we have to do that also. Then we have to treat prophylaxis, and we have to form our opinion, and we have to inform police. As far as the second part is concerned, sedation part.
Yeah.
So if patient is not comfortable because due to pain or any other reason, then you can offer sedation also. But for that, consent of guardian is very much required, because patient cannot give consent for sedation or anesthesia if at all you are going to go.
So then who can give the consent for examination of this victim?
So if patient is more than 12 years, patient herself can give consent. And if patient is less than 12, then any guardian who have brought that patient can give consent.
And sir, if victim refuses for examination, then what to do?
So if victim is more than 12 years, she can refuse. But at that time, we have to explain her what is the importance of examination. And we have to take her into confidence, because many a time she is scared. And that is why also she may be refusing. But if we convince her, and if we can explain that what is the importance of examination and what will be the result after examination, then she may be ready. But if she is reluctant and not giving consent when she is more than 12 years, you cannot force her for examination.
So the same is like if victim is not willing and relatives insist for examination,
No, we cannot.
then
We can.
the-
If she is more
then
than 12.
okay. And if victim is willing but relatives they are not willing,
So willingness on part of relative is not required.
okay.
If patient is more than 12 years and if patient is ready to give consent for examination, we have to proceed with examination.
And what is the provision about the presence of the parents or relatives when the examination is being conducted?
So there is provision in POCSO Act. We may allow or we have to allow rather parents or relative in the examination room. But many a time patient may not be comfortable with presence of that very relative because in few of the cases person who has brought that victim could be accused. It is also observed. So we have to ask patient separately in private that are you comfortable if person who has brought to you be present in examination room? If she is comfortable, then you have to allow.
Okay.
Because
Thank
many
you
a
so much,
time
sir.
patient is brought by a member of CWC.
Yes.
He or she cannot be a relative and they insist to be present at the time of examination. We have to allow, no issue. But they may not interfere in our procedure, in our examination, collection of evidences, etc. They are simply observed.
Thank you so much, sir. You have
Thank you,
clarified so
sir.
many things.
Yes.
So next we have Dr. Bharti Kalra ma'am, who's the past president of Karnal Society. You can see her painting.
Yes.
And she
yes.
also likes gardening. So over to you, Bharti ma'am. These hangings are really beautiful. Bharti ma'am?
You have to unmute yourself.
Bharti ma'am, you have to unmute yourself. Yes.
Yeah, you're done. Hello. Good evening, sir.
Good
Our
evening.
best wishes for your candidature,
Thank
and
you,
we
madam.
wish that you will win the election.
Yes, thank you. Thank you, madam. Thank you.
So, this is a very beautiful webinar and very informative. I am noting down the points also along with it. So, the question related to me is, what is the role of doctor as an expert witness in case of sexual assault or rape? So, first of all, I want to ask, we should get the written consent on the OPD slip, or we should need a separate paper for that? And what is the role of doctor?
You can take a consent on separate paper also. And it is very simple consent. I give my consent for my examination.
Okay.
And everything was explained to me. What could be the implication of examination, how this examination will go further, and about this collection of evidences, etc. So we have to mention it should be informed consent.
Okay. So what is the role as expert witness in sexual assault?
So in court of law, in this type of cases, we are many times called as an expert witness to opine whether she was victim of sexual assault or sexual harassment or penetrative form of sexual assault. So we are the important person to form opinion and to justify that opinion in court of law by our history, by our findings, and whichever treatment we have given to the patient. Sorry.
Yes, so at times, when such a patient comes to a private practitioner, so we get scared. So whether we should treat and such a patient or not, and we try to refer them to government facility.
So you are under obligation to examine and treat. You have no option. Because under section 27 of POCSO Act, any person who is victim of sexual offense is brought to you. You have to examine, you have to treat, and not only that, in that emergency part, without cost, without charge, you have to treat. And once patient is stabilized, and if further treatment is required, then you can ask patient to have option whether to continue treatment with you only, then after you can charge. And if patient is willing to go somewhere else, then you have to shift patient to another center.
So should we get it in writing or we should make it the verbally only?
Yes, naturally in writing, because many a time patient or patient party may go hostile and it becomes difficult for us to prove in court of law. So it should be always in writing.
Thank you, sir.
One last part remained.
So citing that it's an MLC case and it requires police requisition or magistrate order.
Merely on that ground, when patient is brought to you by a relative or a school teacher or any other person, in this situation, merely on that ground, it becomes a MLC case and police requisition is required or magistrate order is required. Cannot be the ground for refusal. You have to examine, you have to treat, you have to form opinion. So you are under obligation.
Thank you, sir.
So no police requisition or magistrate order is required for examination or even treatment also.
Thank you, sir. Now we have Renu Chuk, ma'am. She likes traveling. Traveling. She is also the past president of Bhivani Society. So there.
Good.
Over to you, ma'am. Renu, ma'am.
Good evening, everyone. Am I audible?
Yes, ma'am.
I think my camera is not working. Can you see me or not?
No, you are not visible.
You are not visible, but just audible.
You are audible.
Okay, I think my camera is not working. There is some problem with the laptop.
But
so
you
I'm
are
sorry
very well
for
audible.
that.
But you are audible.
Speak on.
You can
Sir,
go. Yes.
good evening, Dr. Patel and Ma'am Asha. So first of all, my best wishes to you for your upcoming elections, and we wholeheartedly support you. Will support you and hope to see you as a president, our next president. So, sir, it's a wonderful panel going on, and after a long wait, my turn has come rather. So I would hurriedly ask the question. There is a 17 years old girl who visits a private hospital with history of sexual assault. The doctor asks her to go to a government hospital as it is a MLC case and has to be examined by a government doctor. So, sir, is it mandatory that a victim of sexual assault has to be examined at government hospital?
No, it is not mandatory that this type of cases are only to be examined and being treated at government hospital also. In private hospital also, one has to examine, one has to give treatment, and one has to opine.
Okay, means even if we are not willing, we want to get rid of all this police and all, still we are not.
Yes.
I mean, we are not, we cannot do that.
Yes,
so
and
we have to examine.
Inform police then.
Okay.
Yes, next.
Okay, even as a practitioner, we were all the time thinking that we can refuse. Only the government doctors, they are supposed to.
No, it is not like that.
Usually, sir, in routine, we don't get such patients in practice. Mostly they go to the government hospital.
It's fine, it goes to the government hospital.
We don't get
at all. Many times what happens, mother brought child with history of, just we mentioned in one of the cases, vulvovaginitis, itching vulva, or discharge.
That is just for the treatment, yeah. That is
for treatment. But when we come to know by history or so that she is a case of sexual offense, then we have to inform. We have to treat, of course, but we have to inform.
But sir, one thing I want to ask: how can we be sure that this infection is because of some assault? So it could be otherwise also due to bad hygienic habits also. Many times the young girls, they fiddle with something. I mean, some sort of masturbation or something like that.
Whatever we opine, we should be in a position to justify. So if we have all the evidences in favor that she is a victim of sexual assault, then only we have to stamp as a case of POCSO. If you do not find any favorable findings, then you have not to. Because in one of the cases, it happened that there was a quarrel between two families. They were residing nearby, and she was bitten like anything. There were some injuries over perineum also, over vulva also, but there was no sexual intent in this condition. They filed case under POCSO, but it was not proved that there was sexual intent or any sexual harassment or sexual assault or penetrative form of sexual assault. And case was decided in favor of that accused. So there should be sexual
case of domestic violence only. Could be domestic violence only.
Yes.
Yeah, that may be the done.
And last part.
And is it necessary, sir, for a female doctor only to examine sexual violence victims? Or maybe male doctor can also do? What is your opinion?
If female doctor is available, then it is always preferred to be examined by female doctor. But if female doctor is not available and patient is brought in an emergency, say for example, if she is bleeding, so merely on that ground that female doctor is not available, you cannot refuse patient. You have to examine, you have to treat that very patient as far as bleeding part is concerned. Of course, in few of the condition, you have to shift that patient to higher center also. But primary treatment should be given by you, and you will have to inform police, because once you come to know that she is a case of POXO.
Okay. Okay, sir. Thank you very much.
Yes.
Thanks a lot. Thanks a lot, sir.
Yes, welcome.
Thank you, sir. So next we have Dr. Nishi Gupta. So she's the Vice President of Ambala Society. She writes poetry, does dress designing, and also does embroidery. So over to you, Nishi ma'am. Madam had joined.
If she is there, fine.
Hello.
Otherwise-
Yes, ma'am.
Hello.
Yes.
Am I
Welcome.
audible now?
Yes, welcome.
Yeah. Good evening, Dr. Patel and Dr. Asha.
Yes, good evening.
And my question is, if the girl is 17-year girl is in relationship with her boyfriend, and when she failed to have her menses on regular due date, she got anxious and visited the doctor. Worried that she was already pregnant, she discloses to the doctor about her several sexual relations with her boyfriend. And she also discloses she was worried about her conservative parents, how they would react, whether she would continue her studies, what will happen, whether to inform the police, whether to inform the girl's parents.
So as far as information to police is concerned, always yes, because she is 17 years, less than 18, it becomes a case of POXO. Whether to inform girl's parents. So if in this case she is 17 years, when she is more than 12 years, and if she is not willing to inform her parents, then we cannot and we should not inform parents.
Okay. And whether to counsel the girl about safe sex and advise about pregnancy and care.
So I mentioned prior also.
Yeah, you have told.
If she is willing to continue pregnancy, because in few of the cases, it is also a situation that she is willing to continue pregnancy, then we have to offer her proper antenatal care, and we have to advise everything related to antenatal care and future delivery planning also.
Okay.
Yes, next. Yes.
Thank you.
Yes, ma'am. Welcome.
So, sir,
it is all, I think.
Next,
in
we
my
have
question,
Dr.
it is
Chandan
all. My
Kachuru,
best
ma'am.
wishes are to you.
Thank you, madam. Thank you. Thank you, Nisi, madam.
Dr. Kachuru
Yes.
ma'am has been there, sir, from the very beginning.
My pleasure.
Very good.
Does a lot of gardening. See the vegetables, you feel like having salad right now.
Very good.
So over to you, Chandan ma'am.
Thank you so much, Dr. Patel and Dr. Asha. Dr. Patel,
Yes, welcome.
really, when you were introduced, I wanted to endorse that introduction by Dr. Asha, that you are always approachable at a second, not even a second. Thank you so much, sir, for all the help every time. So my question is, a 17-year-old girl had eloped with her boyfriend and became pregnant with 16 weeks of gestation and requested for MTP. Now she's not willing to reveal her boyfriend's name to police. Her father is refusing to give consent for MTP. What should doctor do? Whose consent to take?
So here she is 17 years. If she is not willing to reveal name of her boyfriend, we cannot insist. But we have to inform police. Even if she is not willing, then also we have to inform police. As far as MTP part is concerned, she cannot give consent for MTP. Some major person should give consent for termination of pregnancy. And in this act, word guardian is used. So any person who guards the patient is guardian. Need not he or she could be her parents, father, mother or so, or any relative. Any person who is major can give consent for termination of pregnancy. Because in say for example, medical college hospital or so, head of the unit, head of the hospital department, head of the hospital can also give consent in good faith of patient for termination of pregnancy. But if she is not willing, I mean her father is not willing, then we cannot force her father to give consent.
So once informed to CWC, father consented for
Yes,
MTP.
yes.
So MTP done, and now father is insisting the product of conception to be sent for further investigations.
Yes.
But says she does not want to implicate boyfriend with DNA analysis. So what should the doctor do?
So in this situation, many times when a termination of pregnancy is very much required and nobody is ready to give consent, then you can inform CWC. Member of CWC can also give consent on her behalf for termination of pregnancy. But in this situation, whenever you are terminating pregnancy, you will have to preserve product of conception in saline and it should be handed over to the police. And you have to inform police that we are going to terminate pregnancy of this patient you are requested to send your representative to collect product of conception. If you have informed and if police doesn't turn up, that is up to police. You are out of problem.
So there's one question I wanted to ask you. I got a call from Bangalore from one of my patients, and her maid was pregnant. She was a 16-year-old girl and she was pregnant, and she told me, "Ma'am, how can I help her?" So as a person, I mean,
but still you have not examined patient. So
I have not examined.
So how you come to know whether she is pregnant and what is the gestational age? So in this situation, unless and until you examine patient, you cannot opine.
Yes, sir. But what was the? I mean, is it important for the people also to know that besides doctors, even the teachers and whoever knows about the pregnancy has to?
Yes. Under section 19 of POCSO, in that very section, it is exactly mentioned. Any responsible citizen of India. Word is like this. Any responsible citizen of India comes to know that she is victim of sexual offense or she is being misused as a sexual case of sexual offense, you have to inform police or CWC.
Yes.
So any person, even in school, if teachers comes to know, then teacher is also under obligation to inform police.
Yes. So not many people know about that.
Yes, but it is there. Section 19.
Yes. Thank you so much, sir. Thanks a lot, and for inviting me to this webinar.
Dr. Asha, if time permits, some questions which.
So you have 3 minutes.
Okay. Somebody was asking some question in the
Anybody
beginning.
wants to ask any questions?
Yes, sir. I want to
Pramila
ask.
Malik had her hand up for quite some time, so requesting ma'am if she wants to say
welcome.
something.
Sir, if a patient is major, like 24 years, and then she is pregnant from a boyfriend, not from her husband, she wants termination without informing her parents or her family members. What
So
can we do?
as far as her termination of pregnancy is concerned,
In a
when
major.
when she is major,
Yes,
when
sir.
she is mentally sound, she
Yes,
can
sir.
give consent for termination of pregnancy, and consent of husband is not required.
Consent
As
of
far as
patient is.
MTP Act is concerned.
Okay.
But one more case.
Yes, sir.
If her boyfriend is minor, then
The boyfriend is also major.
Then there is no
But
problem.
she wants to hide from her family.
Yes, she can. And
Okay.
we have
So
we
can
have
go
to
ahead.
honor. Yes,
Okay.
we have. If our hospital is registered for MTP
Register
Act,
for MTP. Yes, sir.
and if we are qualified, So
Yes, sir.
observing all the formality of MTP Act, that is consent to be taken in Form C, opinion is to be formed in Form 1, we can terminate pregnancy. But in this situation,
Yes,
we
sir.
have to take two consent. One consent in Form C, which is very much required as per MTP Act 1971, and one informed consent, because Form C consent is very simple consent. I
Yes,
give
sir.
my consent to terminate my pregnancy. It is not informed consent. So
Yes,
we'll
sir.
have to go with one more informed consent. And for that, you have to simply visit Foxy website. On Foxy website with name Foxy Uniform Consent. It is available with 3 medical legal experts, Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad. We have prepared 30 different consent. And in those consent for termination of pregnancy by medical method and by surgical method is there. So you can utilize those consent also.
Okay, sir. Thank you. Thank you, sir. Thank you very much.
Thanks. Thank
So
you.
there's one question
Sir,
from
I
Dr.
have one
Chandran.
question.
Yes.
Sir, I had a patient, unmarried girl, and she was 16 weeks. Her parents and her guardian. She had come with her neighbor and her parents. 4 persons were there. They had given consent, and I had terminated her pregnancy. And she had given the consent. We don't want any police information because she was 24 years of age. So now she has filed a complaint against for rape. That her neighbor has done rape on her. So what should we do?
When she had been to you, she was major?
Yes, sir.
She was major.
Yes,
So
sir.
this is also one typical situation we face in our day-to-day practice. When patient is major, patient is unmarried many times,
Yes, sir.
or married, but she wants to hide this pregnancy with her spouse or so, or she is widow, or she is judicially separated. These are some typical situations. So in this situation, when patient is major, when patient is mentally sound, your center is registered, you are qualified, you can terminate pregnancy. But to be on safer side, not to end up into this type of problem, because many times there could be quarrel in between, and she may lodge complaint that consent was given to that boy against promise of marriage, and now he is not ready to get married. So it was case of rape. So we may be put into trouble, but not to end up into this type of problem. Always make a habit at the end of consent given by patient. In her own writing, it's fine. Otherwise, you can also write and patient may sign. It was result of consensual sex. I have no complaint against anybody. I do not want to inform police, because at that point of time, patient is very clear. She has no complaint against anybody at that point of time. If at all she has complaint, then we have to inform police, and I mean she will inform complaint to the police. But when she is not interested to have complaint at that point of time, and if we have written these 3 lines, it is a result of consensual sex, I have no complaint against anybody, I do not want to inform police, you are safe. In future also, if at all she lodge complaints against that very boy, then also you are not challenged in legal way. And in very recent past, in one of the cases, Supreme Court has an observation. When you were living in relation since 10 years or 12 years, and now you are lodging complaint that it was case of rape, how court is convinced to believe that it was case of rape? So it is very difficult in this type of situation for us also, if we have not mentioned like this. So always mention these 3 lines and you are safe.
Sir, Dr. Chandan has her hand up for, Dr. Promila Malik has her hand up for a long time.
Yes, welcome.
If you would just say what you have to, because we'll have to end in a couple of minutes.
Yes, just 1 minute.
Yes.
Excellent panel, Dr. Patel, and
Yes,
all
welcome,
the
madam.
best for your forthcoming elections. I just wanted to ask that POCSO is for protection of children against sexual offense.
Yes.
But when it is a consensual sex between 2 minors, or it is a case of child marriage, do you consider again it is as a sexual offense because it's a consensual?
Yes,
and
because then we were able to refer a consent. And in famous case of Samira Kohli versus Prabha Manchanda, it was decided in 2008. What is ideal consent in Indian context? And in that very, it was mentioned that minor cannot give valid consent. So consent given by minor is not legal consent. So even if they both are minor, they have sexual relation with consent, their consent is not valid in eye of law.
In one case, in which
more than
18
12
and
years.
6 months patient was 39 weeks pregnant. In that case, if you inform the police, sometimes the police starts torturing the couple and the family, and they just start asking for money. And how do you prevent that?
That is not our area, because we have to inform. Because if we fail to inform, then there is a provision
Then we
of
are
6
to be
months
blamed.
imprisonment, and we cannot afford that. We have to simply inform. What police has to do or what police will do in future, that is up to them.
Sir, I have a quick question, sir.
Yes.
Can I come under POCSO Act? It means all the child marriages less than 18, if they are, and they are
Here simple means, as far as POCSO is concerned, here age matters. Marital status doesn't.
Age is less, but both are, I mean, with consent, they are getting married. So
No,
still,
age is the main factor here.
so
There
it
is
means
different
even the
area.
neighbors, they
I
can
think the
make
parents should be
It is considered as an irregular marriage in eye of law. That is separate issue. But our role as a doctor, once we come to know, we have to inform police. Simple.
Sir, I have a quick question, because I get a lot of patients for the ultrasound. Say, for example, a patient who is 18 and a half years old comes for ultrasound, but she already has a child of 2 years old. So should I inform the police?
Yes.
But this time, if you come to know that again she is pregnant, then also you have to inform. And
No,
once
18 and a half is a major, like she is pregnant, but she has a child of 2 years old in the like.
So at the time of conception of that very child, she was minor, and
Yes,
you came to know, so you have to inform.
No, I have come to know, like when she has come now, then also she needs to be informed for the previous mistakes.
Yes,
okay.
We have to.
Okay, sir. So actually more of social awareness is needed, because otherwise the doctors are always in a soup. So that's there. Thank you, sir, for the excellent and all the best for the upcoming
Because
elections.
what happens, investigating officer may harass you in this type of situation, even if you are innocent by other means. If you fail to inform, there was no bad intention on your part, even then police officer may harass you. Why you didn't inform? And they may put case against you under section 21 of POCSO Act. So it becomes
we
very
are not. We are worried about our harassment as well as we are worried about the family's harassment. Like they already have a child to take care. There is another pregnancy. The husband is not earning that much, so the girl will always be in soup if the husband is arrested.
But in this type of situation, courts are also very much sensible, because in one of the cases in Supreme Court has very good observation. Then when they are happily enjoying their marriage life, these were the exact word, when they are happily enjoying their marriage life, even if they both are minor, as per POCSO Act, of course, it is a sexual assault, but we do not want to disturb their happily married life, and when they are happy to enjoy. So Supreme Court didn't consider husband as accused, and they were caught free in this case.
So in Gurgaon, most are happy, sir.
And court has a observation also.
Court cases.
Court has a remark that if marriage life is more than 1 year, in this type of cases of minor, and if doctor has failed to inform, then doctor will not be held responsible. But in this situation, we are waiting for that judgment and exact wording of Supreme Court. So we can take as a precedent, because whenever this type of cases are decided in Supreme Court or in High Court or so, these cases are taken as a precedent in future. But we have to go to word as far as judgment is concerned, because in that it was observation that if it is more than 1 year married life, then doctor should not be held responsible.
Okay, sir. Thank you, sir.
Yes.
Thank you.
Sir, I think we need to end the session.
Yes.
We have already overshot by quite some time, and Nilesh is here trying not to say anything.
Yes.
Thank
so
you so
if
much.
at all any query remains, they can put to me on my WhatsApp. I will answer.
Thank you, sir. Thank you so much.
Oh, yes.
All the best to you.
I am always there. I am always there to assist you in any given situation. So please feel free to have a phone call to me. And
Thank you.
simple update at the end to consider my
Hello,
candidature
Subhahi.
for President Foxy and
Hello.
Chairperson Food and Drugs and Medico-Surgical Equipment Committee from Asha J.
Thank you.
Namaskar.
Thank you, sir.
Thank you,
sir. Best
thank you
wishes.
everybody from Haryana Obstetric Gynec Society. Thank you all delegates.
Thank you.
And thank
Thank
you,
you so much.
Corona, for being behind us in this whole program. Thanks a lot.
Thank you.
Thank you,
Dr.
Thank you so
Asha and
much.
Dr.
Sir,
Patel.
Thank
for
you.
Very
I'm
having
nice.
ending the
this
session.
brainchild and running the program. Thank you, Mala ma'am. We'll take half a minute and get your feedback, please. You've been here
Yes,
to
Mala
the
madam.
program.
Very quickly.
You're
You are
muted,
muted, madam.
ma'am.
Please
You're
unmute.
muted.
Mala madam, please unmute. Yes, welcome.
No, these were very relevant questions you discussed on the POXO Act. I think we need to be educated on this, definitely. And I really appreciate that you're always available. Asha, you conducted this webinar very well. It was
Thank
really
you, ma'am.
nicely. It was a pleasure being here. I was listening to most of your proceedings. So
Thank you.
Thank you so much.
very
Have a
nice.
good.
Thank
Thank
you.
you.
Thank you.
Thank
Goodbye.
you.
Thank you
Goodbye.
so much.
Goodbye, Dr.
Now I'm
Thank
ending
you.
the session.
Shubhratri.
We have successfully
Thank you,
completed
everyone.
this webinar.